been tremendous excitement about looking at new potential devices for valvular heart disease, obviously, at this meeting. And we're joined now by Michael Borger, who's going to talk to us a little bit about new prosthetic devices. So, Michael, you know, I trained at Stanford in the 70s, and there was, you know, we had the old Starr-Edwards valve and the new tissue Hancock valves and those sort of things. But there's now a sutureless aortic valve. Is that correct?
Yeah, there's actually 3 different sutureless aortic valves that have CE mark approval in Europe. There was the Medtronic Enable valve, and then Sorin Perceval, and then most recently Edwards Intuity valve. And all 3 of them represent a real interesting and exciting area because there's 2 patient populations that are targeted. There's patients that have long ischemic time, so ones that have complex combined procedures, and you're trying to minimize your ischemic time, and you use one of these sutureless aortic valves. But a more important or a bigger patient population that I think is more prevalent is patients for isolated aortic valve, that these sutureless products will enable minimal invasive surgery. So it's easier, it's faster, it's been noted across the board. The operative times are shorter, the implantation times are very short, and it looks like a real exciting area that hopefully will eventually cross the shore here to the U.S.
I'm sure it will. Michael, tell me, obviously I'm not a surgeon, but so if you're doing this in direct access, okay, which makes sense to me, how do these things stay in place?
So they're all based on stent technology. The one from Medtronic and the one from Sorin are a nitinol self-expanding stent, and then the one from Edwards is a stainless steel balloon expandable stent, which they borrowed from their technology from the Sapien TAVI system.
And how about annular calcification and things like that? That's when you know, how is that a problem?
Well, I was taught as a resident that you always had to take out all of the calcium. Okay. We know from the TAVI story that's not true. Right. For TAVI, we don't take out any of the calcium, and for these products, you take out the calcified leaflets, but you don't go chasing a bunch of calcium into the wall of the aorta or the annulus. That would actually be detrimental, because if you end up with a hole in the annulus, there's no suture to repair that hole at the end. So it's a sort of a middle ground, but it definitely speeds up and eases a minimal invasive approach, because you don't have to do an extensive calcium debridement, and yet you still get a good result without a paravalvular leak.
You gave me 2 examples, I mean 2 classes of patients. I certainly understand both. When would you not use this type? It sounds fabulous to me. It sounds like a great benefit for the patient. When would you not use these type of valves?
Well, all 3 of them are circular. There's a circular sealant with the left ventricular outflow tract, so you want to watch out for patients that have, say, a large piece of calcium in the aortic annulus that's making it non-circular, because you will have a paravalvular leak in those patients. Or sometimes, you know, with bicuspid aortic valve patients, you can get a real oval-shaped annulus. And with conventional valve replacement surgery, you could always form the patient's annulus to the sewing ring of the valve with all of those sutures. Right. With these, that's not an option, and therefore it's got to be circular, and sizing is paramount. It's very important for sizing.
What about AI? Okay, and in other words, in those patients who, you know, and I know that you do valve sparing procedures all the time, but if you had big annulus or big sinotubular junction, can you use it?
They go up to 27 and 29 sizes, but right now they've excluded patients with pure aortic insufficiency. In the future, it might be an option, and certainly those types of patients, they'll tend to be the young patients. Right. And tend to be the ones getting the valve repairs. So
this is primarily for AS. Let's shift a little bit, because I know that you also gave a talk on TAVI valves, and what's coming down the pike with TAVI valves?
Well, there's 2 new valves that received CE mark approval last fall. There's the Jena valve and the Symedes. Both of them are inserted transapically, and both of them have sort of feelers that go into the sinuses of the aortic root and get some sort of stabilization and positioning there before the final deployment of the valve. And these feelers are the rationale behind them is to get a more anatomic insertion of the valve and to minimize the risk of things like coronary artery obstruction. So they're very interesting technologies. And then there's also a similar one from Medtronic, which is undergoing clinical investigations in Europe. And St. Jude has their own new TAVI valve, which is currently just undergoing clinical assessment. So there's a whole range of products that are going to be increasing our options.
Last thing I'd ask you, and it's just from having been involved in some of the early transapical procedures. They've done a lot of the transfemorals, but it seems to me that the direct aortic really makes a lot of sense for the TAVI type valves. Am I wrong in that assumption?
No, you're definitely right. A working distance of only 10 to 15 centimeters from where your hands are and where the actual valve is being implanted makes it a much more precise method than going over the femoral artery and having to navigate the aortic arch. That's definitely an advantage for the transapical approach. The disadvantage is, of course, that the patients need to be done under a general anesthetic, and it does involve a small thoracotomy. But our experience has been those patients tolerate the small thoracotomy very well, and you can usually extubate them within a couple hours after the procedure. It's not a big problem.
So there's a lot of exciting things in new prosthesis, you're telling me.
There's a lot. There's so much investment going into this area right now. This is an explosion in valve therapy that I don't think has ever been seen before. And I think the next 5, 10, 20 years are really going to be exciting for this area.
Super. Well, thanks so much for joining me. I appreciate it.
My pleasure, Randy.